I want to welcome everyone today to the HHQI Underserved Population Network call. We thank you for taking your time out today, and I think you're going to really enjoy today's presentation on Everyone with Diabetes Counts, the impact of rural southern West Virginia. The handouts, as well as additional links, are located currently on the HHQI website under the Up tab. You can download those now or after the call, whatever you prefer. You will be muted, obviously, for the call today. So any questions that you have, please put them in the Q&A tab or the chat tab, and we will address those when we get to the Q&A session. And I say this every call, please write your questions in as we go along so that it's out of your mind, and you can go ahead and put those down. That way you don't have to remember later on. So let's get started today with this session, and I'm going to introduce first Natalie Tappy. She has 30 years of nursing experience, including more than 20 years of coordinating clinical research trials to study the safety and efficacy of experimental drugs. During that time, she has coordinated research trials for about a dozen diabetic medications. She has facilitated many community outreach efforts at churches, schools, physician offices, and centers on aging in order to recruit and enroll participants. Ms. Tappy has helped in the development and centralized clinical trial centers at over a 900-bed hospital system, and later became the co-founder and the president of clinical operations for her own research company. She has worked for WVMI since 2005 on various projects, including a program for American College of Cardiology and Medicaid review. But since August of 2012, she has served as the lead project coordinator for the Everyone with Diabetes Counts program for Medicare beneficiaries. Ms. Tappy has received her Bachelor's of Science in Nursing degree from Marshall University and her Master's in Advanced Clinical Nursing from George Mason University. So with that, I am happy to turn over the call to Natalie.
Thank you, Misty. Good afternoon and welcome. Thank you for taking your time out of your day to be with me for an overview of Everyone with Diabetes Counts project. Again, my name is Natalie Tappy, and I'm the lead project coordinator for Everyone with Diabetes Counts in West Virginia. Next slide, please. Today we'll accomplish the following objectives during our time together. We'll begin with an overview of the EDC program and the Diabetes Empowerment Education Program process, how we are evaluating our success in reaching our goals, lessons that we have learned, and barriers that we have encountered with DSME. We will review some teaching tools and what we've used in class to teach Medicare beneficiaries, and also how we can collaborate with home health care. Next slide, please. Next slide, please. Okay. I don't have my slides.
Okay, Natalie, we're on the Everyone with Diabetes Counts.
It came up. I'm
okay.
Sorry.
Okay.
West Virginia Medical, sorry about that. West Virginia Medical Institute serves as a quality improvement organization for the state of West Virginia and was awarded a special innovative project in September 2012 from the Centers for Medicare and Medicaid. West Virginia was chosen as the only rural state in the U.S. to participate in this program for the 10th scope of work. West Virginia Medical Institute is providing diabetes self-management education classes to teach diabetic patients why they should and how they can manage their diabetes for a healthier life. We are also hoping to provide assistance to healthcare providers that are seeking to become certified diabetes centers. Along with West Virginia, there's 2 other states that are participating in this program. New York is participating in enrolling Medicare beneficiaries from the Hispanic population, Texas is participating in enrolling Medicare beneficiaries from the African American population. Next slide, please. This is a look at West Virginia and our counties that we are actually teaching in. In order to have the most impact through our education, we needed to find the most underserved counties in West Virginia that had little or no diabetes self-management education programs. As you can see, the dark blue, which includes Mason and Jackson, Nicholas, Greenbrier, etc., those were our original 13 counties. As we continued on with the program throughout the year, at the end of 2013, we added the other counties, such as Putnam, Roane, Clay, and Braxton, in the light blue, because we needed to increase our enrollment and to reach out to more underserved populations. We have in those counties 5 registered nurses and 2 LPNs that are teaching DSME classes. They also serve as master trainers in the diabetes self-management education using the DEEP program. We also actually have been in a few of the other counties. If somebody asks us to come into one county, we will go into the county to teach, just so that we can help whoever needs to be helped. Next slide, please. So why did CMS choose West Virginia? Well, approximately 200,000 people in West Virginia have diabetes. Of those 200,000, 62,000 are undiagnosed, according to the Diabetes Prevention and Control Program. Year after year, West Virginia is ranked one of the top states in the prevalence of diabetes. Unfortunately, we also lead the nation in comorbidities such as heart attack, stroke, and obesity. In some of our southern states, we're approaching southern counties, we're approaching 16% of the population. Next slide, please. And another reason that they chose West Virginia is because less than half of West Virginians with diabetes have had any education about the disease, or access to any type of diabetes education or self-management is limited or non-existent in most of our rural counties. Excuse me. Next slide. I just wanted to put this slide up. I actually got this from the Rural Health Association, the West Virginia Rural Health Association. They actually just completed the book that they published just recently for 2013, and it shows the average diabetes rate in West Virginia along with the obesity rate. And as you can see, unfortunately, West Virginia is very high in both obesity and diabetes. If you see the dark purple, that means that we are higher than the state average, excuse me, for obesity and diabetes within the state. If you look at the, look at the green, it's lower than the state average for diabetes and obesity. So looking at, say, an example would be Wayne County, which is over to the far left in the dark purple. It's actually high in both obesity and diabetes, and that happens to be one of our target counties. Next slide, please. I also wanted to include this slide, too, because it shows where we compare to the rest of the United States. Now, while this only is 2010 statistics, it does reflect how poorly we take care of our diabetes in the state of West Virginia. If you look in 2010, our diabetes prevalence was 11.7 compared to that of the entire U.S., where they were ranked 9.2%. And as of 2013, in America's Health Rankings that was just published, West Virginia ranked 50th in the nation for diabetes prevalence. We fell from 48 in 2002. So how they came about this ranking was, it was calculated by the percentage of adults who answered yes to the question, have you ever been told you had diabetes by your physician? This didn't include gestational diabetes or pre-diabetic. Next slide, please. And the ADA has just released this startling new statistic. They estimate that the total cost of diagnosed diabetes has risen to $245 billion in 2012 from $174 billion in 2007. That's when the cost was last examined. This represents a 41% increase over a 5-year period. That to me is astonishing, actually. And if you look, one of the reasons that Medicare is doing the Everyone with Diabetes Counts program is because the cost for diabetes care in the U.S., 62.4%, is provided by government insurance, which is Medicare and Medicaid. Private insurance is less than half of that at 34.4%. Next slide, please. Also, the ADA, within the last few months, has recognized Everyone with Diabetes Counts as a promising practice. What that means is practices that can be applied to community efforts aimed at reducing the risk of type 2 diabetes and obesity in high-risk populations, including youth and adults. We also try to, when we go to recruit physicians' offices, hospitals, clinics, we try to tell them that the ADA recognizes this program so that maybe they'll be more amenable to us coming in and teaching DSME, or diabetes self-management education, because we know that it's such a problem, especially we're finding more and more younger people being diagnosed with type 2 diabetes. And West Virginia is 5th in the nation for childhood obesity, excuse me, as well. Next slide, please. So what is diabetes empowerment education? That's next slide, I'm sorry. That's the program that we chose to teach DSME. It was developed by the Midwest Latino Health Research Training and Policy Center at the University of Illinois at Chicago. And it was developed to address specific problems that were associated with the prevention and management of diabetes by training community health workers to become educators and outreach workers within their own communities. Now, as I said, for us, we actually have nurses who are teaching the program for this particular special innovative project. However, we've also trained 60 community health workers in West Virginia this year, or from 2013 to 2014. We're actually holding train-the-trainer classes throughout the duration of the project. We hope to at least train 100 community health workers so that we will have sustainability within this program if we aren't around to teach DSME. Next slide, please. Okay, so what is involved in the DEEP curriculum? The focus is on, as I said, prevention and control of diabetes through 8 learning modules. Those are understanding the human body, diabetes and its risk factors, physical activity, meal planning, exercise, and stress management. It also is designed to enhance the clinician-patient communication skills and aid in decision-making. And one of the most important principles of the DEEP curriculum is the empowerment theory. By empowering people, what I mean by that is we empower them to take charge of their health and their health care. And by doing that, we hope to improve quality of life, because participating in one's own health care can actually make the world a difference to anyone who has diabetes. An example of empowering a patient, one of the most simple that I can think of, would be when we have class, we ask patients, how many of you take off your shoes and socks when you go to your physician? Some say they do, some say they don't. So we encourage them, or we empower them. When you go to your physician's office, take off your shoes and your socks, hop up on the table so that when the doctor comes into the office, the exam room, he can say, oh, that's right. you have diabetes, I need to check your feed. So that's one simple way that we hope to empower people to take care of their own health. Another way that we include people or have people learn about the DEEP protocol is by participating. What I mean by that is we don't stand in front of the class to lecture patients, because most of the time if we do, we don't have their attention and they're not going to listen to us anyway. We want to encourage them to become involved. We use whatever means we can to engage the patient by demonstrations, role-playing, games, visual aids, flip charts. Any type of participatory technique, we use it. We find that it's very beneficial, especially if we're dealing with the elderly population. I also want to tell you with the DEEP curriculum, it's encouraged by the authors of the program to deliver this program by community health workers and peer educators. It's also taught, which is very important, on a 6th grade level with low literacy materials because in West Virginia alone, we have such a high literacy rate that the low literacy materials that we use really help out in teaching the program. If nothing else, just using the pictures alone helps convey the message of how important DSME is to beneficiaries. Next slide, please. Okay, and I want to talk to you a little bit about what do we use, how do we get the patients engaged. Next slide, please. Okay. This is an example of one of our coordinators. We're actually teaching at a senior nutrition center in Jackson County, or Ripley, West Virginia, and we actually had a large turnout for this class in particular. We had over 25 participants. Some didn't have diabetes, but they wanted to listen anyway, but the majority did. So when we're teaching in large settings, we usually have 2 people who team teach, and myself and one of our coordinators, that was Teddy, was actually with me. And we begin by teaching about the body itself, diabetes and our body. What parts of our body does diabetes affect? And we pass around all of the different body parts, the brain, the kidney, the heart, the pancreas, so that they get a feel for what the body parts look like and what we're talking about when we start referring to the complications of each of the body parts. Then we also do a fast food analysis. This particular one happens to be Subway. But what we do is we look at 5 different restaurants. We're actually we get the beneficiaries in a group of 4 to 5, depending upon how many are in your class. We give them a menu, or it's actually laminated cards with certain items of food that we give them on a key ring, and we ask them to look at the fat or the carbohydrates, the sugar, and the salt content. Once they do that, then they have to calculate how many teaspoons of fat, sugar, and salt are within the meal they've been chosen to analyze. We then give them a plate, a 9-inch plate, and they have to actually, per teaspoon, count out lard for the fat, sugar cubes for the sugar, and teaspoons of salt. By the time that we're finished, most people are disgusted by the amount of lard and sugar they see on foods that they eat every day or restaurants they go to every day. And I myself have not been to a particular fast food restaurant since I had to do this exercise last in January of 2012. The fat content alone was 58 grams. So we had 58 grams of lard sitting on our plate. So needless to say, myself nor my children have been back to this particular fast food restaurant. It really brings home, it's the most powerful demonstration of what we eat and how what we put into our bodies on an everyday basis. Next slide, please. This is our good food versus our bad food. Believe it or not, these are fake foods. They demonstrate, we use these to demonstrate to the classes what we consider as diabetic educators good food and bad food. They're very useful because we've actually had a lot of people think that they're real food that we've actually had out on display. What we do when we're teaching this is we ask them, okay, if you don't like what you see in the good food category, if you see something in the bad food category, what can you do to make that healthy or more healthy or less bad? What will it take to make that something that you can eat and fit into your healthy eating plan? An example we give them, if you're going to eat, that happens to be a hamburger with lettuce, American cheese, and a slice of bacon. The bun is underneath. But what we suggest is, okay, if you want to eat the hamburger, perhaps take the bun, remove the bun from the hamburger. You don't eat the bread. Remove the processed American cheese. Or leave the bacon and take the cheese off, or take the bacon off. There's a multitude of ways that we can encourage them to make their food a little bit healthier, because we know that people are going to eat bad food. We all do. But if they can make healthier choices, we want to encourage them to do that. Another example would be if you took the pizza, which really in reality is 2 slices, but for most of us, we eat that and more. So to make the pizza healthy, what we could do is take the pepperoni off, or bake the French fries instead of deep frying them, or substitute them all together for a baked potato. It's particularly difficult in Appalachia to convince people to eat more healthy, and I'll get into the reasons why as we proceed through the class. Proceed through the, I think I'm teaching a class, as we proceed through the program. Next slide, please. Okay, in teaching diabetes and complications, as I told you, we engage the participants in any way that we can. The model, the felt model to the right is actually, it's my daughter. I traced her and cut out her, I don't know how her arms got so long, but I digress. Anyway, we took the felt cutout, in the DEEP protocol, they gave us the body parts. We put them on colored paper, we laminated them, and we go through each one of those that are on the felt board. And we go through the heart. And how does diabetes and its complications affect your body? What does diabetes do to your lungs? What does diabetes do to your intestines? And along with that, we also have, if you'll look to the left, I made those myself actually in teaching because it was much easier to actually, instead of doing it every single time that we have a class, it's much easier to have your boards ready to go so that you're not distracted, and you make sure that you go over every single point when you're talking about the complications, because again, those are the most important parts of the curriculum is what does diabetes do to your body. And one of the things that we tell them when we're teaching is that diabetes is an equal opportunity disease. There's not really one organ in your body that it does not affect. So we want to go over these complications so that they know that they need or should or want to keep their complications and the risks lower. You'll also notice on the flip chart that when we do use the flip chart, all of the descriptions are in different colors. We've learned that with the DEEP protocol that it enhances visual learning, that people are able to concentrate. What is glucose? Glucose is sugar in the blood. It's in a different color than glucose converts glucose comes from the food we eat. They're all in different colors so that your eye goes to each and every single line so that it enhances the learning. We found that very successful, and more people definitely pay attention. Whether we're teaching Medicare beneficiaries or caregivers, families, friends, we don't turn anyone away. Anybody who wants to come to our classes comes to our class because we feel that how can we, even though it's for Medicare beneficiaries, how can we, in good conscience, turn someone away who wants to learn about diabetes? Next slide, please. Now, this is kidney function and heart disease. Now, these look like very simple props, and they are. And I will tell you that most of our props came from the dollar store. Most of the visual aids that we use are very inexpensive. Now, there are some, the body parts and this slide to the right, those were very expensive, but those the ones that are least expensive far outweigh those that we did have to pay quite a bit of money for. Now, what we use the colanders for are our description of kidney function. If we say to the beneficiaries, now, if your blood sugar is in good control, that means your kidneys are functioning properly, then you won't have any filtering problems because we know that the kidney is one of the filtering organs in our body, so that when we look at the colander with nothing in it, we know that our waste products go through and are filtered out through our body. However, if our diabetes is not so well controlled, we do have some problems with our filtering. So that when we pour the fluid through the colander, some of the fluid is actually trapped because some of the filtering of our kidneys is impaired. Then we get to the third colander, and we tell them, now this is what happens when you have no kidney function at all. Your filtering system is completely gone. Nothing can get through. So what happens then? We tell them, of course, you have to have dialysis, because dialysis becomes the artificial kidney because your kidneys can't filter out the waste products because of the diabetes, what the diabetes has done to your body. Then the next picture we have, I want to explain to you, are the tubes. And these are one of the most powerful demonstration tools that we use. And one would not think so looking at them, but how we demonstrate them, we tell them, this is your blood, this is what is going through your veins and your arteries. We have the first tube, which is on the bottom to the left. That, if you'll look at it, shows all of the red blood cells clumped up at the top of the tube. When we turn the tube over, this doesn't allow any of the red blood cells to travel through our bloodstream. So it's very slow because all of the glucose molecules are attached to the red blood cells, so it slugs along and goes very slow. The next tube is if your blood sugar is semi under control, the red blood cells will travel through the veins and arteries a little more quickly. Then we have the last blood tube, which shows all of the red blood cells going up and down freely, meaning your blood sugar is well under control, and the glucose molecules are not attached to all of your red blood cells and taking out all of your oxygen so that they flow freely through your veins. So when people see this, they're very mesmerized, basically, for lack of a better term, as to how the blood flows through their veins and arteries when their glucose is not under good control. And then lastly, the picture shows the clogged artery with the red blood cells unable to travel through the cholesterol plaques because the person has not taken care of their diabetes. Therefore, the thinning of the walls of the arteries and the plaque has built up so that the clots form and you have heart disease. So those are some of the tools of the trade that we use, and they're very beneficial, and they also help in getting our point across, especially if someone does have problems with reading the handouts that we include. Next slide, please. So deep in the community, how do we get our patients? Where do we find them? We have to use every type of community service agency in our targeted communities. We utilize the agencies on aging, the federally qualified health centers, state associations, existing health-based coalitions, providers, physicians, faith-based organizations, home health agencies, anyone or anybody in the community that can help us, we've contacted them so that they can help us with encouraging people to come to DSME classes that we're holding within their counties. Next slide, please. So how DEEP works, again, by collaborating with state and local agency, advocacy groups, organizations, councils to implement activities to decrease health disparities in our targeted counties. We do collaborate with our diabetes coalitions, or we also try to prevent, if there already is an existing diabetes or certified diabetes education program, we make sure that we don't duplicate services, that we work together. We do have an organization, we work with West Virginia University Extension agents with their Dining with Diabetes program. And by forming that partnership with them, we teach our food portion of the diabetes, of the DEEP program, along with the extension agents actually cooking the food while our coordinators are teaching about the food portion of the diabetes. We also want to, any type of materials that people want, we provide them with the materials so that they're able to continue the DSME. Okay, next slide. So while we're doing all this work, we still have to be able to say that this program works. And how we do that is by administering a pre and a post test to the beneficiaries. Of course, the pre-test is before the class, and then the post-test is after they've graduated the class. Then we select 250 patients there's 2,500 participants that have to have Medicare. They at least have to be a Medicare beneficiary. Of those 2,500, 250 we're collecting clinical measures on, such as A1C, blood pressure, weight, lipids, and dilated eye exam. At baseline, which is prior to the diabetes classes, at 3 months, and at 6 months after completion. Once we collect those, we submit those to CMS for evaluation to determine if indeed the diabetes self-management education classes are working. Okay, next slide, please. Now I want to go over a little bit about our outreach materials, what we use to get people to come to our classes. Next slide, please. And the first one that I want to talk about is our middle flyer. We used that to kick off World Diabetes Day last year. And I'm not sure if you're familiar with him, but Landau Eugene Murphy was season 6 winner of America's Got Talent, and he agreed to be our EDC spokesperson. He actually lives in Logan County, West Virginia, and that happens to be one of our target counties, and his mother has diabetes. So he felt that this was a good way to give back to the community. So he agreed to be our spokesperson. And we featured him on billboards, radio, public service announcements, television, and we were able to get him out into the public and have him that you need to come to these classes.
Hey, Natalie, are you still on? We may have lost connection.
I think we have lost her.
Okay. Hang on just a second.
Okay, well, while we're working on getting her back, I'll let you guys see about getting her back. I'm going to go ahead, this is Ms. Kevich, and I'm going to go ahead and jump in with a couple bullet points till she comes back. I think we've seen a few things in chat we've kind of been throwing out there. A lot of great tips and great points for using props, which is really an adult learning principle. Man, I really see a nice kit coming together that could be utilized by using the lard, the salt, the sugar cubes, as well as the fake food. I mean, how easy is that? And allowing them to do choices. We have provided for HHQI some of the My Plates, which you can look at good plates and talk about selection, but that hands-on, that interaction, moving foods around, even allowing them to create a plate to start to see what's healthy and what's not healthy. Okay. And Natalie, if you come back on, just jump right in and let me know you're back. Okay. And the other thing, so I really, you can get a lot of the children's toys with the food. What a great way to put that together into little kits that could be shared amongst clinicians that are looking at their, for populations of diabetics. You have a nice toolkit. The other note I kind of put down too is, but with that, you also have to have some standardized teaching plans outlined so that you're consistent with your clinicians in providing that care. And you could utilize, we'll talk about the resources at the end, but the home health quality improvement, disease management, CPEP for diabetes as part of that. Okay, Natalie, wonderful.
We'll come back. I didn't realize. Yes, I didn't even know that it dropped me. I apologize. I don't know where. I think it was where I was talking about Landau.
It was. You were talking about Landau, and that you even had him go out into the community to really touch and connect with the community. And that's where we were.
Okay, great. Again, I apologize for that. I didn't realize that I had been dropped. So, as I said, Landau actually lives in Logan County, so he was very, very gracious in allowing us to use his likeness and be able to go out into the community. We also attended several of his Christmas concerts, and we were able to have a booth, not a booth, but a table, and be allowed to reach people that way. And he also promoted during his Christmas concerts the EDC for us. The next outreach that we used was the Got Sugar. That is actually a parody, of course, of the Got Milk campaign, because everybody in West Virginia says they got the sugar. So we decided to utilize these cards for pharmacies and physicians to hand out. And then the last card was it was a newspaper ad that we put in during Valentine's Day that was, we used the catchphrase, love your community. And we decided to have a train the trainer actually in Kanawha County, which is one of the largest counties, one of the most populated counties in West Virginia. And we actually used it twice. I apologize. This is the one that we used for the Mercer County one. But we also used it for Kanawha County as well during Valentine's Day with the heart, because we thought, what a better way to entice people to come to a train the trainer course to be able to give back to their communities, come to the train the trainer, graduate, be able to teach people that you know need diabetes education. And we actually had very good turnouts at both classes, both trainer. The one I did in Kanawha County actually had 9 people attend, and I graduated all 9 people. Most were retired nurses, but we also had several lay people. The one in Princeton, West Virginia, which I just completed, actually had 5 people and 2 were nurses. So we are getting out to the public and engaging more lay people to participate. Next slide, please. Okay. These outreach tools, the prescription pad to the left is actually considered one of our best practices for EDC. We racked our brains to try to find a way to encourage people to come to DFME classes. So we developed a prescription pad to give to physicians, nurse practitioners, PAs, in hopes that they will use them to refer people to the classes. And actually, we've had patients come up to us and say, my doctor gave me this prescription, and I was told that I had to attend this class. So they actually are working when people use them, because as long as the physician finds it, they think it's a real prescription, so they come to our class. The next thing that we hand out is the med tracker, and this is just a token that we give to them at the end of our classes to keep track of their medicines and their doctor's appointments, and it just gives them a running list. And we actually had to reorder them because they're very popular. Next slide, please. And this was one of our most enjoyable projects. This was developing the Everyone with Diabetes Counts cookbook. We took down-home Southern recipes and made them diabetic-friendly. If we didn't actually change the recipe, we included nutritional information. We had a certified diabetes educator review this with us, and we supplied all of the nutritional information that was necessary, and we also put in the diabetic-friendly serving suggestions, the nutritional allowances if they wanted to substitute sugar for a replacement, so that we didn't change the recipes too much, but allowed them to still eat them, but just modified in one way or the other. Our cookbook includes staple items that are common in Appalachia, like beans and cornbread, but we also included recipes for squirrel, raccoon, deer, and rabbit. We typically raffle off a cookbook after each class graduates, and we actually are on our second order of our cookbook too, because that was also very successful. And a lot of people can actually obtain this by downloading the e-version of it as well. Next slide, please. And this pamphlet is one that we developed to give to everyone in our class. Now, we try to, again, make this on a 6th grade level. Sometimes some of the words we had trouble with, but we pretty much did a good job of describing symptoms of hyper and hypoglycemia, along with signs and symptoms of heart attack and stroke. And I just wanted to tell you a quick story, actually a success story from using the pamphlet. We had a gentleman who was in one of our classes, and they happened to be talking about cardiovascular risk factors for diabetes. They reviewed the signs and symptoms of heart attack. He went home. The next day, he told his wife that he just didn't feel well. And his wife asked him why didn't he feel well? What was the problem? He said, I don't know. I feel like I have to belch and it won't come up, and I feel a little bit of pressure in my chest. Well, one of the side effects, the signs and symptoms actually, not side effects, that they had talked about the day before was, pressure in your chest, sometimes not being able to expel gas, or feeling that you need to belch, could all be signs of heart attack. So the man persisted with telling his wife that he was uncomfortable. He just could not belch. He took Maalox, didn't help. He finally took an aspirin, and then he went to the ER, ended up that he actually had to have 5 stents, and the physician told him that had he not come in when he did, he probably would have died. So the wife, they weren't able to come to the next class. They called and they told the coordinator that they wanted to thank her because she had saved her husband's life. And just by reviewing the signs and symptoms of a heart attack, the gentleman who was in our class was able to recognize it and seek help. Okay, next slide, please. And I may be running out on time, so I'll quickly go through some of the barriers. As you know, with all projects, there's barriers to overcome and lessons learned. Next slide, please. So one of the barriers that we encounter quite a bit is, and I'm just speaking for West Virginia, is the fatalistic attitude. My family has the sugar, so it's only a matter of time. People feel they don't need DSME because they're going to die anyway, especially in rural areas. We also encounter a lot of people who are angry, whether they're angry and depressed because they have diabetes or whether they're angry because they think we're coming in to tell them how to eat. They'll tell us, you know, I've been eating this way for 80 years. You're not going to tell me what I can and cannot eat now. We try to tell them, you know, we don't want to tell you what you can and cannot eat. We want to tell you maybe how you can change or modify or take a smaller piece of that cake instead of eating the whole slice, or having that hamburger with the french fries, but getting a small hamburger and getting a small fry, not the supersized version. Another barrier is religious reasons. We don't usually have class on Wednesday nights because everyone goes to church in southern West Virginia on Wednesday night. We also, another barrier that we encountered was people's access to affordable, nutritious food. They have to rely on food banks or cheap, unhealthy foods from grocery stores. Another thing that we encountered was because we live in West Virginia, the mountainous terrain plays a big part in how we travel to our classes. Sometimes it takes us over 2 hours to get to some of the classes that we have to teach. Next slide, please. In a lot of the rural counties, there is no public transportation available, so people have no way to come to our classes. Weather impacts our class attendance, especially this winter. Probably the worst winter we've had, and when you travel on these roads, very dangerous, especially in the mountainous regions. We also had, I'm not sure if you are aware of it, but in West Virginia, in early January, we had a chemical leak in our water system throughout 9 counties in West Virginia, and water, drinkable water, water we cooked with, bathed with, was not available to us for over 3 weeks. So we were unable to have classes during that time. People's access to quality health care, they have no way to get there to be able to go visit their doctors, to get to hospitals. Lack of support from the medical community. It's been difficult at times because we find it hard to get past the office manager or to get past the medical assistant who's in the office who won't let us talk to the physician, because we know the physician believes probably in what we do. They just don't have the time to be able to see it through. So we want to be able to tell them, you know, you don't have to. We will do it for you. Just allow us access to your patient. That also ties into community support, because a lot of times the community, if it doesn't affect them directly, they're at times hesitant to help us. And lastly, those that are trained, those community health workers that we train, they're not compensated. So they're actually doing this out of the goodness of their heart and free of charge. Now, some states actually do have community health workers that are compensated, and unfortunately in West Virginia we don't. Next slide, please. So what are the lessons that we learned? We learned that you always, I can't impress upon you more than that, to assess your audience, know who you're teaching, because utilize the low literacy materials if you need, because a lot of times, you forget who you're teaching. You forget what you're teaching, and that's why it's so important to use what I showed you before, if at all possible, by engaging the patients, encouraging them to participate in the role playing, using the flip charts, using the model, using repetition. Be prepared for questions. We've learned that since most people have not had, diabetes self-management, they have a lot of questions. We have to be prepared to answer them. And then we learned that persistence does pay off eventually. Going back to the physician's offices several times, going back to the clinic, to the practice manager, utilizing connections to get into the door. If one of your friends works there, we've used that. If one of your family members works there, we've used that. It's like being a salesman. Next slide, please. Also, you have to have effective advertising. One of our most successful campaigns is the direct beneficiary mailing, where we actually have a letter signed by their physician mailed to the patient from their physician. That has been one of the most successful campaigns we've done. We also, of course, have done flyers, posters, radio, TV, web, direct mail campaigns. We learned, again, not to have classes on the first and third of the month, because that's when people get paid. So they're more interested in filling up their car with gas, going to the grocery store. Again, we've learned not to have classes on Wednesday night because of church. We also have learned how to tell people to prepare food from when they get it from a food bank. One of the coordinators that we had, this is another one of our success stories, and I'll be quick when I tell you, but it's a story I think I need to tell you. We had a lady come up to one of our coordinators at the end of one of the classes, and she talked to the coordinator in private and said, "I think I'm killing my husband." And the coordinator was like, "Okay, and how do you feel that you're killing your husband?" And she said, "Well, I want to be totally honest with you. We can't afford food. We can't afford fresh fruits and vegetables. We eat what we can from the garden, or we go to the food bank." Well, what do they get from the food bank? You get rice, you get pasta, you get white bread, and you get potatoes. So she said, "I cook my husband, as is common in Appalachia, fried potatoes in butter with onions every single night. And when she takes her husband's blood sugar 2 hours after he's eaten dinner, it's 300, 320. And she said that, he doesn't deviate. He wants that. We have to eat that because that's what we have." So the coordinator said to her, "I have an idea if you will allow me to give you another way to prepare the potatoes." And she said, "Absolutely." So she said, "Take the potatoes, put them in water, parboil them, dump the water out, parboil them again. Not to make them mushy, but just make them so that you're still able to slice them. Dump the water out." What does that do when you parboil something that has a lot of starch? It sucks out all of the starch. You're actually pouring some of the starch down the drain. So she said, instead of using butter, use olive oil. The lady said that she had gotten a free sample of olive oil from the food bank. Somebody had donated it. And instead of using the butter, use the olive oil, fry the onions, and do the potatoes after you've parboiled them. Next class, the lady comes back. She comes running up to the coordinator, tears in her eyes, said, "Thank you, thank you, thank you. I did what you said." He didn't even notice the difference in the food that I prepared for him. He ate it. 2 hours later, his blood sugar was 160. So that is a success for us. We helped one person. That has significant meaning to us. And just as a bit of trivia, in the olden days when they used to parboil the potatoes, they would save the water because the starch would gel, and that's what they used for wallpaper paste. So that's my little bit of trivia for today. And then actually, churches we found sometimes are very hard to get into unless you have a contact, a parishioner, the clergyman. Sometimes they're willing to help, but a lot of times it's very difficult. Okay, next slide, and then I will be ready for questions. how can we collaborate with home health? Next slide. We feel that by being in the home health community, you can help with DSME by attending the Train the Trainer course, becoming a licensed community health worker so that you can go out into the community and teach. You want to encourage those family members, friends, and caregivers that you see in the home to participate in DSME. Help their loved one who has diabetes by have them attending class. Utilize all of the outreach materials that are provided to you so that people can participate in the local DSME classes in your area. EDC is actually supposed to be taught in every state in the upcoming scope of work. So by attending the Train the Trainer, you're already ahead of the game because you'll be hearing more and more about everyone with diabetes counts in the coming months. Next slide, please. Also, help us promote and sustain DSME in the communities by referring those patients that you see that are either newly diagnosed or you think that they need a refresher. Encourage the physicians to refer the diabetic patients, or holding the classes within your own home health community if you graduated from one of our Train the Trainer classes. And if you haven't come to one of our Train the Trainer classes, then maybe provide DSME classes at your facilities if you can. And one of the quick things, next slide please, and that goes with how we sustain DSME. Next slide please. Because really sustainability is the hallmark of this project, because working within the communities, training community health workers, establishing and promoting diabetes coalitions is really the only way to bring diabetes education and the ability of patients to self-manage their diabetes to the forefront. Next slide, please. And that's really all that I have for you. I'm sorry that I went over. I would like to take this opportunity to thank all of you who attended. And I just wanted to leave you with a little bit of diabetes humor. While diabetes is not funny, this is what we strive for, actually, in our classes. And I'll be happy to take any questions. And again, thank you to the HHQI for allowing me to present to you today.
Well, thank you, Natalie. This has been so very helpful and inspirational as well, and a lot of great ideas. We've been doing a lot of chat on the side with taking a look at some of the ideas that you had on your slide. But we do have some questions already in the queue for you, and we're going to jump right into it. Michael has a question. Can you discuss the full-time staffing requirements to operate this program through the QIO? And before you answer that, on the call today, there are a lot of QIOs that are participating in the call, as well as home health agencies. So this is an answer for the QIO.
Okay. We actually have, as I said, we started with 4 full-time nurses and 2 full-time LPNs to go out within the actual 13 counties. They're actually, like I said, employed full-time. They're home-based because we felt we needed people within those communities. I'm based actually in Kanawha County, which is the Charleston, which is the largest community, but all of our other nurses are based within where they teach. So they know a lot of people. They're able to go out and talk to people that they know to get classes within the community. We also have 1 full-time administrative assistant because there's so much copying, there's so much reporting that we have to do that we couldn't do it without a full-time assistant to EDC. We also have a half-time communication specialist who helps us with all of our letters, all of our mailings. It's very daunting at times, but, you know, with all of us, we make it work. I hope that answers this question.
It does. Thank you so much. And I have 2 more questions, so we're going to continue quickly here. We have, how many sessions are included in the DSME training, and how long is each session usually? From Tiffany.
Okay, for the DSME, for the D
training,
Oh, the trainer? Okay, the trainer.
No. Start with the deep, because she actually came back and asked the next question, which is for the trainer.
Okay, for deep, typically in our program, it is 4 to 6 weeks in length. You typically have 1 to 1.5 hour to 2 hours. I'd say probably 2 hours. By the time everyone gets there, gets registered, at least 2 hours to go. Go over all the modules. We teach consecutively. Could take us a month, could take us a month and a half. Usually during the day, we also do Saturday classes. We do have evening classes. Usually we do 2 modules per day, per session. We switch up the modules. We always leave the food module to the last day because that's what they're most interested in, so that's what gets them to come back. For Train the Trainer, for the deep program, is a 3-day session with a master trainer, and it's usually all day, 8 to 4.
Okay, great. And then we have another question from Michael. How did you collect the data for the lab test, A1Cs and lipids?
We actually developed a fact sheet that once they have to be completers, meaning they have to be a Medicare beneficiary, either straight Medicare or dual eligible, and they had to have obviously sign a medical release form. Then we had a fax form developed, and we actually faxed the form to the physician with the medical release form and a letter from CMS that explains exactly what our program does because physicians' offices get a lot of faxes, and we didn't want them to, okay, what does CMS want now? But this enabled us there was a form where they actually filled out at baseline 3 months and 6 months what our requirements were. Then they fax it back to us. So that's how, and we actually have, I failed to mention, we actually do have a part-time person who collects only clinical measures for us because it is such a large undertaking. So she actually is solely responsible for collecting clinical measures.
Okay, great. All right, well, thank you. I appreciate everybody staying on that has stayed on. We are running to the end. So if you have additional questions, you're very welcome to send those into HHQI mailbox. We'd be very happy to, I'm assuming, Natalie, you'd be very happy to help answer any additional questions.
Absolutely.
Okay, I believe there were a lot of great information for all of us to take today. And if we'll turn to the next slide, we're going to run through these. This will just take just about a minute. We do have our disease management, diabetes focused best practice intervention package, as I mentioned earlier, that are some resources and that you can utilize, and those are the topics that are within it. It includes a clinician evidence-based practice, as well as diabetic medication references for clinicians, and a My Diabetic Education workbook that could be utilized even with the food and all the items that were included in the presentation today could also be added and used with that. Next slide, please. And we also have we do have our bulletin board template. We provide you with a template, and you can use it as is or modify however you'd like. Next slide. So it's also this is our stoplight tool that is free for you to be able to utilize using the red, yellow, and green, and it is based for health literacy and related to self-management. Next slide. Do look for our next up call, which will be on the 23rd from 3 to 4 Eastern. Carol Siebert and Karen Vance, they are OTs that are nationally well known, are going to be talking about using occupational therapy to optimize outcomes. And the focus will really be on patient self-management and empowering patients. Next slide. And you can register already. Next slide. And when you leave today, and you've finished the survey, which we hope you would answer, that really does help us going forward. But then you will be sent to our next webinar, our national webinar, which is the Gravity of Falls, Evidence-Based Prevention Strategies. This is going to be for an hour on April the 29th from 2 to 3 Eastern Time. It will include 4 speakers. We'll be looking at multifactorial fall risk assessments, looking at changing and modifying thresholds, prevention intervention, as well as we'll have a pharmacist on to talk about the pharmacy issues with different medications. And you can register for that already. And this is kind of like a it's not even announced to all participants yet. So this is the first time you'll be able to go ahead and register. Next slide. And then just our connection. We thank you very much for attending today, for the questions, and again, for the great work that Natalie and her team are doing in West Virginia that is applicable and sustainable really in all of the areas, either in doing community-based programs, but using the concepts that we heard today and utilizing that within our home health regulations and guidelines related to the insurances. And with that, I'd like to thank you all and hope to see you back again soon.